You're feeling a little discomfort in your neck and jaw. You also have nausea, short of breath, and keep having this recurrent sense of fullness in your chest. What do you do? If you're experiencing anything like this right now, call 911 and get to a hospital right away. If not, please stay tuned for Health Watch. Hello, I'm Terrence Affer Anderson, and this is Health Watch. Most of you know that what I just described a moment ago was not all, but just some of the symptoms of a heart attack. Are you at a risk for a heart attack? Do you know all of the signs and symptoms? Do you have a family history of cardiovascular disease? Do you know how to minimize your risk? That's our topic today on Health Watch, and please pardon the pun, but as we engage in some very heartfelt and insightful discussion on cardiovascular disease and heart health, I thought I'd invite a Health Watch veteran back to the show. A seasoned and gifted cardiologist, it gives me great pleasure to welcome Dr. Keith Newby back to Health Watch. Dr. Newby received a Bachelor of Science in Biology from Norfolk State University and later earned a Doctor of Medicine degree from the Eastern Virginia Medical School. He completed an internship and residency at the Emory University School of Medicine and completed a fellowship in clinical training in cardiology with an emphasis in invasive electrophysiology at the Duke University Medical Center. He is, in fact, board certified in cardiovascular disease and clinical cardiac electrophysiology. That's a tough word. And September 10, 2010, he founded and opened the Fort Norfolk Medical Plaza. It gives me great pleasure to welcome Dr. Keith Newby. How you doing, man?
I'm doing well. And yourself?
Electrophysiology. What is that anyway?
That's actually the study of heart rhythm disturbances. So, we all have to study general cardiology, so you spend a couple of years with that. But in cardiovascular training, usually now it's more of a 4-year fellowship training program. So you have to do your medical school, which is 4 years, and you have to do 3 years of internal medicine, and you have to do 4 years of cardiology training. So 2 years of general cardiology training, and then 2 years of electrophysiology.
Electrophysiology. And that has to deal with, I'm going to try and impress you now, but that has to deal with arrhythmia?
Arrhythmias, yep. So that's, I tell you what I always like to, when I'm talking to people about heart disease, I like to use analogies to help people understand things a little bit better. One of my famous analogies I like to use is a house as the example, like like your heart. You're in your house, you have your foundation, your ceilings, your walls, your rooms, you have doors that lead from room to room.
Right.
Well, your heart is structurally like that as well. You have heart chambers,
with the chambers,
which are like
yes.
rooms.
Right.
The doors are like the valves that separate the chamber to chamber, room to room in your house.
Interesting.
I like to look at, you have plumbing in your house. When,
right.
when you cut on the faucet, you expect the water to come out. Well, that's like your coronary arteries, which supply oxygenated blood to the different parts of the heart, much like a irrigation system in your garden. But you also have electrical circuits in your house.
Right.
You flip a light switch on, you expect the lights to cut on.
Right.
Well, the heart has electrical circuits as well.
Right.
So, and that's what actually creates the electrical impulse that makes the heart beat. So when you're talking about electrophysiology, that's the study of how electrical circuits flow through the heart.
I always knew that you were a genius, but did you come up with this analogy on your own?
Actually, I did.
Yeah,
Actually,
I'm not at all surprised.
I have found that if you talk to people
right.
in terms that are familiar to them, because the heart is not a hard organ to understand, but you just have to be able to find similarities.
Right.
And I think that when you kind of develop these similarities, it just helps people to understand it better. I just happened to stumble. I think I was trying to explain the heart one day to somebody, and they just couldn't get it, and I sat there and thought for me. I said, wait a minute, this has got to be somewhere I can explain this so that they understood. And it just popped in my head, the analogy of I think I just looked at something. I think I looked at a sink, and I saw that faucet, and it just kind of dinged. I said, something, let me try this, and it has worked for me ever since. So I use that all the time in my explanations to people about heart disease.
You should get someone to do an animation of a heart that looks like a house.
that's
You know,
a good
you should do
idea.
that. Yeah. Listen, the last time you were on the show, it was some time ago, back in February 2013. And at that particular time, we talked about something I had never heard of before, broken heart syndrome.
Right.
Okay, and I'd like for you to just briefly describe that. But in doing so, if you could make the distinction between cardiovascular disease and heart disease in terms of a simple layman's definition.
Well,
let's start with broken heart syndrome.
Well, all real broken heart syndrome is a disease entity, I will say, for lack of a better term, and that's usually in the form of some heart attack or heart failure like symptoms that people have as a result of some stressful situation in their life. You think about some life-changing event, death of a loved one, or maybe some financial failure, and everybody's different with how they deal with stress.
Sure.
People that manifest stress in certain ways, and others do it other ways. Where in broken heart syndrome, that can really show signs of a heart attack without them actually having blockage in their heart. What happens is, and I see this a bit, you got the EKG changes, everything consistent with that. Clot formation can come in the heart as a result of increased stress. That could cause a blockage of an artery.
Right.
Transiently. Usually when we get people in, we see other heart attack evidence, the EKG changes. We sometimes see the enzyme elevations in the bloodstream, but when we take them to the catheterization lab, nothing there.
Nothing's there.
You know, and that is well documented. I've had several people myself with that, and then you find out there's been some stressful situation in their life, either again the death of a loved one or some other entity that they're dealing with that is for them extremely stressful.
That's very interesting.
Yeah.
The cardiovascular
disease. Essentially, I mean, they're kind of interchangeable into some degree. Heart disease, if you look at the definition of heart disease, all that is anything that affects the heart or the great vessels. The great vessels are the big arteries that come out of the heart and the veins that bring blood back. So when somebody says, well, you've had a stroke, well, a stroke is a blockage of blood flow to the brain. Well, that's considered heart disease. Why is it considered heart disease? Because the arteries that supply blood to the brain are connected to the heart.
Sure.
Same thing if you talk about vascular disease. If you have a blockage in a leg artery, same difference. It's considered heart disease, even though the blockage may be well down in the leg. It's considered heart disease because the heart is connected to those vessels.
Understood.
So it's really just anything that affects the heart of those great vessels, the aorta, the arteries going out to the legs, or the veins bringing blood back to the heart. That is considered heart disease. Cardiovascular disease is just more of an interchangeable term of heart disease.
That's kind of a global
kind
definition.
of global. I mean, both of them are global terms, and they're used interchangeably. But cardiovascular, meaning heart vessels. Heart disease, heart vessels. So it's really, they're interchangeable, but that's just more of a broad term. I look at that almost like if you say the term car. Say, okay, I bought a new car.
I feel another analogy coming.
Well, yeah. And, if you look at the term car, well, you have different types of cars. You got a Lexus, you got a Pinto, you got a Gremlin, if you remember that. You have a Chevy, a Ford. There are different formats of cars or different forms of cars. The question is, what form are you referring to? Well, cardiovascular disease is the same thing. So if you look at the heart or the great vessels, we talked about that issue of electrical circuits, plumbing, a structural problem. If there's a structural problem in the heart, that's considered cardiovascular disease or heart disease. All those are interchangeably part of it, but you can single out and really go down into the finite details. If you have an arrhythmia, well, is it a supraventricular, meaning in the top chamber of the heart, or is it a bottom chamber rhythm disturbance? Is it atrial fibrillation, which is a disorganized rhythm? Is it a regular supraventricular tachycardia? Is it an atrial tachycardia? You have different forms of arrhythmias. So you could really drill down to the nth degree on many of these things. Coronary disease, there's different formats of that as well.
With all of the the implications of heart disease. I think it's probably a good idea to just take a look at some of the numbers. I did some research, and I'm going to have them put them up on the screen here, that suggests the incidence of heart disease and how we are dealing with that. And if you could put that up on the screen for me, we'll see 635,000 people in the U.S. have a new heart attack every year, and these are yearly numbers. Some 300,000 Americans have a repeat heart attack. 1 out of every 7 American deaths is related to heart disease.
It is still the #1 killer. Despite the research, despite the advances we've made, heart disease is still #1. It probably will always be #1 for various reasons we can talk about. But I found that by far, that aspect of the 635,000, it's a probably pretty accurate number. You think about, new cases every year. That's why it's #1. But it's all based on risk. And the risk factors that develop heart disease is where, to me, our focus needs to be. Because it should be all about prevention.
Well, let's talk about risk factors. I know that there's a distinction between major risk factors and contributing risk factors. Can you talk a little bit about the major risk factors?
Well, the major ones are typically the broad-based chronic illnesses. Hypertension, diabetes, hypercholesterolemia or high cholesterol levels, family history of heart disease, and I do want to emphasize on family history. A lot of people don't understand when we say that what that really means. Some people may think if there's cousin Bob 2 times removed, because they had a heart attack that at 92 years of age, that's a family history. That's not what the situation is. Premature cardiovascular disease is a genetic predisposition. So if you are father, mother, brother, sister, first-degree relatives, age 55 or less, having a heart attack or some form of heart disease, that's considered a family history, a significant family history.
Significant.
Yeah, so those are people that have genetic predispositions for heart attack and heart trouble. If you're older, if you're 75, 80 years old, well, that's different. Those patients or individuals, they're at risk regardless. But it doesn't mean that you as a family member has a genetic predisposition for heart disease. So that's one of the other major risk factors. Tobacco use. Some of the newer ones or the contributing ones are things, other types of things like obesity that can contribute to the formation of hypertension or diabetes. You talk about stress levels, in people who can be a contributor because some people who are highly stressed out will eat more to gain weight, then they develop these other things. So you talk about contributing, those are things that can contribute to the major risk factors that can lead to heart disease.
In today's political climate, it would lead people to a fair amount of stress.
Yes.
What I want to do is just take a very quick break now, and when we come back, I want to talk a little bit more about the symptoms and so forth, the signs and symptoms, because you made a reference to the vascular, a symptom that you're experiencing in your leg could be heart disease.
Yes.
Okay, so we're going to come right back in just a second. I want to thank you so very much for joining us. We're going to come back after this very brief break. Stay with us.
Any questions?
What kind of service plan does this come with?
Unlimited.
Can I keep my same phone number?
Absolutely.
How do I change the ringtone?
Just hook it up to your computer.
Does it have a camera? What's the warranty? Does it come in silver? Can I put my party shuffle on this? Does it have a 3.5 millimeter headset jack? You sell a lot of these?
It's the one I carry.
You ever get those phantom vibrations in your pocket?
Any questions?
No.
Are you sure?
Yeah.
Ask questions. For the 10 questions everyone should know, go to ahrq.gov.
Okay, Keith. Some time ago, we talked about something called SCAD, spontaneous coronary artery dissection. I got it right, didn't I?
Yes, you did.
Okay. Can you tell us what that is, and what are some other types of heart? I guess that's not heart disease, is that?
Well, yes, a form of heart disease, because anytime it's a tear in the vessel, it's a spontaneous tear. So sometimes you can have, I don't know if you heard the term aortic dissection.
Yes.
Well, that's a tear in the main artery that comes out of the heart. Coronary artery dissection is just a tear in the coronary arteries. and it could be, there's a host of possibilities. Usually you see it in that it's more common in women than men. You usually see it in that age range of 40 plus, but you can see it in a younger population as well. I've had a few 20-plus-year-old people who've had spontaneous coronary artery dissection. But essentially, it's a tear in the vessel, and that tear can go down the length of the vessel. And as that tear is going down, it creates an accumulation of clot and material that can lead to heart attack.
I see.
So, you can have somebody die from coronary artery dissection,
well imagine.
especially if they're not really discovered early enough, and that early detection is always key. Now, the whys we still don't always know. There are some disease processes that you do see with that. Right. Sometimes some of that stressful things we talked about, stressful lifestyles, some people who have connective tissue disorders such as like lupus, rheumatoid arthritis, anything that can affect the connective tissue can do it as well. So there are ankylosing spondylitis, which is some of these more rheumatologic terms you'll see.
It sounds like you're using profanity or something.
Yeah, I'm trying to see what I can do to kind of catch you off guard with some of the
Well, that
terminology,
always happens to me. Yeah. But listen, I don't want to catch you off guard here, but we had some conversation before we began the tape, and I'd like to get to that. But before we do that, let's talk a little bit about the symptoms, the signs and symptoms. And then I always tell folks, I don't always, but traditionally, I'll say we're going to go off script. We're going to definitely go off script after we talk about these signs and symptoms, because the conversation that we were having earlier is something that's very important and near and dear to us. Signs and symptoms.
Well, signs and symptoms. Well, typically you think about it, the heart works on a supply-demand basis. So the more activity you do, the more blood flow is required of the heart. So if somebody has an occlusion of blood flow, look at it here, one of my analogies again. If you think about a car, you're stepping on an accelerator. Say you're in a residential neighborhood going 10 miles an hour. Well, 10 miles an hour, you have a carburetor has a clogged fuel line. At 10 miles an hour, the car may work fine. You start speeding up to a point where you're surpassing the amount of gas you can get to that carburetor, you're going to start getting sputtering. Well, the heart can do the same thing. So people can manifest that as things like chest discomfort. And when I say discomfort, I use that term because a lot of people don't call it pain. They call it discomfort, tightness, squeezing. Some people call it burning in their chest, and some people get short of breath with that. Some people become diaphoretic, or they develop sweating, perspiration, and some people just feel bad. And it's, the hardest thing is when you're trying to get information to somebody to say, I feel bad. And you're like, well, what does that mean? I don't know, I just feel bad. So what I have tried to do is when I hear the symptoms, I try to ascertain how are these symptoms being manifested? Is it with exercise, or is it at rest? Then I start looking at, it's almost like, you look at us as like a detective.
Yeah, I was about to say
I never watch, I don't think I've ever watched a doctor show in my entire life. I tried to watch ER once or twice, but I never could get into it because many of it's too dramatized and not realistic in terms of delivery of medical information, so I could never watch it. But crime dramas, Law and Order, that was my show back in the day. So, so you look at us as detectives. We have to take information you provide, we have to look at the entire picture, and we're trying to see, does this picture fit what we're looking to try to prove or disprove? Do they have coronary artery disease? Do I have to worry about a heart condition? So I'm looking at things like how the symptoms occur. What are their other medical problems? If I have somebody that's 18 years of age who has no medical condition or nothing, I'm going to be less concerned than I am as somebody who's 65, who has hypertension, diabetes, high cholesterol, and they smoke. So I'm going to look at them different ways. Now, you take everybody seriously because, again, that young person could have a coronary artery dissection. But you have to look at the entire picture, and you do the cursory exam, meaning you always want to talk to the patient. You get EKG, a physical exam. You look at the entire picture, and then you see, does this fit what we think would be associated with heart disease, and that's how we make the determination. So
the signs and symptoms of a heart disease to someone like yourself that's doing detective, it could be like incriminating evidence at a crime scene.
Because look at it, and some of it's age dependent. An older person, say somebody who's 85 or 90 years of age, who may come in, they may not manifest chest discomfort. They may not manifest shortness of breath. What I have found, I've seen people where they just, I have like a son or daughter will bring their mother, elderly parent to the emergency room and say, she just doesn't look right to me anymore. She's become lethargic. She's not talking like she used to. And then you do an EKG, you see some massive heart attack occurring. It's more, you have to look at it in its entirety. The way I kind of view the world is you always look at things from a worst, best case scenario.
Gotcha.
Look for the worst initially.
Right.
Get that off the table.
Right.
Then you have time to work through the other things. Some people try to do the opposite. Oh, it's nothing, and blow them off. Then next thing you hear they go home and die of a heart attack. Well, no, that's not happening on my watch.
Right.
Although I know this is called Health Watch, part of it is my watch in the hospital to say I'm looking for you're looking for that clinical kind of scenario that fits the mold of the situation. And I look at everything from how they look, how they feel, what their health problems are. And all that in conglomeration does help to guide you one way or the other in terms of your diagnosis.
Let's talk now about what we were discussing earlier. I made a reference to some of these statistics, and we put statistics up on the screen, in fact. But there's a number of these people, if there's 635,000 people every year that have a new heart attack. Some of these people, those heart attacks can be avoided by better health maintenance.
Right.
And we were talking earlier about people not doing what it is that they should do to take care of themselves. And I really like to, we don't have a whole lot of time here, of course, not enough time to resolve that, but I really like to talk about that. What kind of stuff are you seeing?
Well, a lot of it I've found is a compliance issue problem. If
people complying to your
to what you try to advise them to do. The problem that I have run into, if you look at some of the chronic illnesses that cause heart disease to occur, hypertension, diabetes, cholesterol problems, you think about it, most of those patients have very limited to no symptoms at all. If you have an infection, say you have a pneumonia, you have a urinary tract infection, you're probably going to have some symptoms associated. Right. You have an affected joint. It's going to hurt. You're going to have some issue. You want to feel better. You have 104 fever. You got a hot joint that's hurting like all get out.
Right.
You're gonna. Somebody tells you, okay, you take this antibiotic, you're gonna get better. You're gonna take it.
Right.
Typically, until you start feeling better. If you get 10 days of antibiotics and by day 5 you're feeling almost back to your baseline, I guarantee you probably won't finish that other 5-day course, even though they tell you to do it because you feel better. The problem with hypertension, diabetes, these are typically asymptomatic disease processes. You don't feel your cholesterol being high.
Right.
Most people don't feel their blood pressure being high. Most people don't feel the diabetes. Some do, but a lot don't. So if I'm asking you to take a medicine
and you don't
for an issue that you don't feel, what's the likelihood that you're going to take that pill every day? There are some that would, but there are a lot more that won't. And the problem is, while they're not taking that medicine and they're telling you, but I feel fine, doc, that's not the point. Your blood pressure is 150/100.
Right.
If you continue down this path, it's going to lead to stroke, potentially, kidney failure, heart attack, or sudden death.
No, pardon me, but you're not saying that the majority of people don't do what they're supposed to do. That's just a disheartening minority that are not.
If you look at the data, it says, and this is pretty well documented, that compliance issues occur about 30% of the time.
Wow.
So if you got 100 people, 70 are not going to do right, 30 are. And that is a real problem we have. And unfortunately, so there's no way to really define how are you taking your medicine. I mean, I have patients, man, they'll look me right in the eye and say they're taking this stuff, and they're not. And I found ways of, and I don't want to divulge all of my secrets, how I figure that out, but there are ways that I can figure out if you are compliant. And I tell people all the time, listen, lying to me is not helping your situation.
Right.
My job is to be here for you, to help you live a healthier life and to live as long as you can. Telling me something that's not true is not helping your situation at all. That's not going to make me feel better about the world that you're lying to me. I'm here because I care about you. and I want to make sure you have all you have to have. So that compliance issue is a major, major, major problem we run into. And unfortunately, so if people don't do right, it's going to be hard to really help take care of them if they don't. And unfortunately, so what I'm running into is they will do right after bad things happen. It's an unfortunate reality. It goes back to the health care disparity issue we brought up earlier, that you see if you go into a dialysis center here in Norfolk or go in most places that are big metropolitan cities, you're going to see a proportionally larger African American population in that dialysis center than you ever see any other population.
And that's getting to what I'd really like for us to get into, to have some very genuine and real discussion about. Regrettably, we're about to run out of time.
Yeah.
And I would like for you to provide folks with information as to how they can reach that incredible building that that new facility that you put up.
Well, thank you. Well, the Fort Norfolk building, we're on the 5th floor of the Fort Norfolk building. We have a primary care and urgent care as well as a cardiology practice, and I tried to develop a all-in-one inclusive facility that we can, if you needed, somebody that's say an urgent care situation, we're really the only urgent care that has cardiovascular attachment to it, so we can do a lot of the workup that otherwise would go in the emergency room, and we can do that there and get you pretty much well situated with what the next step should be. But our office number is 757, of course, 624-1785, and we're located right across the street from Sentara Norfolk General Hospital in the Fort Norfolk building.
Well, you're being very humble. You mentioned that your office is on the 5th floor. You put the building up, sir.
Well, thank you. Yeah. Well, I'm just I look at myself as just a humble public servant. I try my best to be there for my community, for my people, to deliver the best care I can deliver, and that's really where it stands for me. Anything else I do for the community. So I don't like, me, man, I'm not a big talk about what I do and how I do things.
Well, if people knew more of what it is that you did, they would probably try and encourage you to go into politics. But we won't have that discussion again.
Definitely won't have that discussion. I'll leave that to other people to do.
Keith, thank you so very much for coming on to the show today. I really, truly appreciate that.
Oh, thank you.
And we want to thank you for joining us for this edition of Health Watch. Remember, you can always watch previous editions of Health Watch online at www.norfolk.gov/Health Watch. If you'd like to drop me a line, you can email me at terrence.affer-anderson@vdh.virginia.gov. Of course, you can always give me a call at 757-683-8836. That's 757-683-8836. For the Norfolk Department of Public Health, I'm Terrence Affer-Anderson, and this has been Health Watch.